My goodness. Got it. Okay. So we know CBT works. I'm sure a lot of you remember this slide that the effect sizes for using CBTP with psychosis and schizophrenia spectrum disorders is pretty good, moderate to large. And so we think that it doesn't probably help quite as much with negative symptoms. And we all know that even with medication on board, some clients still have residual voices that they need to manage. I think we can, and CBT thinks they can, make this better, make this a little bit more experiential for the client. We have worked on helping them to change beliefs. We have worked on gathering evidence and presenting it in a collaborative way. We can change a belief. That doesn't necessarily mean that's going to change the symptom at all. So we move to a more relational way to deal with the voices. So a lot of the folks that we see, voices are a part of their lives forever, even with medication. And some of the voices that they have are even comforting. I don't know if many of you have ever asked, is there a voice that's comforting or soothing in some way? And oftentimes there really is. So we don't want to take that away. And really, they become long-term relationships with a client. They're not going to go away. So we might as well use them to move forward a little bit more. So voices are thought to be, or it has proposed that voices are a part of self. And one of the ways that we begin to define self is dialogically, in dialogue with other people when we're little, right? The only way we know who we are is by talking with somebody else and having some communication, and we learn messages and we develop rules and morals and so on and so forth. And what we end up with is a lot of information that defines who we are. And there's a work side of us, a play side of us, a kid side of us, right? All of those sides of us become what Eleanor Longden would call society of the mind, is what the word is. And we all have that. There's no denying that. I know that there's a very self-critical part of me, and there's a humorous part of me. And that stuff's not going to go away, right? There's a very oppositional part of me. That's not going to go away. But I can learn to work with it. So what we want to do is to develop some evidence here that talking directly with the voice actually can be beneficial for the client. A researcher, Laura De La Zizo, has done a review of the material involving empty chair work. And so I'd like to have us take a look at some of the work that she's reviewed. CBTP for command hallucinations using an empty chair. The goal here is to help the client change their own beliefs about the voice. When we have a commanding voice that's saying kill somebody or stab somebody or hurt somebody, obviously the client doesn't want to do that, right? That's ego dystonic for them. So putting that voice in a chair, perhaps giving it a name, if it has a name, if the person has a vision of that, what that vision would look like, and begin to say to the voice, this is how I feel when you talk. This is what happens to me in my head when you talk. And what I would really like is yada, yada. I would like for you to stop telling me what to do. It's basically setting a boundary. So the client then moves to the chair that represents a voice and takes the voice's position and speaks out of that voice so that a dialogue can take place between the voice and the voice hearer. And the therapist is in a third chair facilitating this conversation, right? So the client is encouraged to share with their voice all of the skills that they've learned, what they're going to do to help minimize damage, what they're going to do to not hurt anybody else, if that's what the voice says. And they may even draw a line and really set a boundary. So you know that we've, in assertiveness training, right, we teach clients to draw the line, and if the other person goes over the line, we have to do something, right? We go away, we go talk to somebody else, we distract or focus. So in this instance, if the voice is not listening, then the client needs to draw a boundary in some way, like I'm only going to talk to you or listen to you for 15 minutes here and there, or set up some parameter where the voice will only be attended to for a particular amount of time. And we continue to try to help that relationship. So questions like, you know, what is it that you're hoping for from me, voice? So the discussion can be done with the client taking the place of the commanding voice, and encouraged to tell how they feel from that perspective. The therapist acts as an intermediary. Now, when this was done, there didn't seem to be a whole lot of difference for treatment as usual. However, let's see, when we add different components to it, things begin to change a little bit. The therapist's work here is to resolve a conflict between the voice and the client, and to have some sort of understanding between the two. There's 3 phases to this: engagement and psychosocial education, right? Telling the client what this is and why we're doing it, to be able to assess and formulate what's happening with the voices and share that with the client, and the dialogical work of talking back and forth with the voice. The hope is that the voice and the voice hearer will happen upon some common goals, negotiate their relationship, and begin to work with one another in a more direct way. So the outcome shows no difference on CIRATs. However, the BAFQ, which is the belief about voices, did change significantly, right? So in the first study, participants were invited to participate in a qualitative study. There were 12, 6 of them, half of them felt less distressed by voices and demonstrated way better control. It's a small sample size, but half is pretty darn good. There's a protocol called making sense of voices. Again, there's significant reductions on the brief psychiatric rating scale and subscale for psychosis. And that's a miracle, right? For those who are the voice hearer, right? That they have less distress is what we're looking for. So reduce distress by modifying the relationship. That's goal number 1. There's 3 phases to it generally. Eleanor Longden would add a 4th phase. The first phase basically is talking about the client, about consequences that might happen as this discussion takes place. The client may be fearful that the voice will talk more and be more aggressive. All kinds of consequences they may think of that we can work through with them. So consider for the client how well they're able to tolerate having that kind of a conversation. It's important to provide them with all kinds of self-soothing skills, perhaps a sign by hand to say when to stop if it gets too overwhelming. As the conversation goes along, you'll discover that there are themes that emerge. So it may be that this person needs to practice assertiveness, right? It may be that the client needs to actively facilitate some conversation. The client is able to see how their behavior might change the quality of the voice that they're hearing. So we can also do experiments. Can we be really assertive with the voice? Can we, what happens if we're aggressive with the voice, right? We can experiment and do all kinds of things to indicate how much control perhaps there is over the voice that the client didn't realize that they had before. So it's working towards a pretty good balance. The power of the voices in some instances were perceived to be greater than they had been before. Despite that, there were improvements in self-esteem and depression. A case study, after 12 sessions, 2 of the 5 demonstrated a reduction in distress from the voices. 3 eventually reported better control, and those effects were maintained at 3 months. There were very large improvements for auditory hallucinations on the PSI-RATS and on the distress subscale. So these positive changes, again, were maintained through 36 weeks, which I think is pretty tremendous. There is a kind of therapy called avatar therapy, which is available, but of course it, requires a screen and some technology, which can be kind of expensive. But what happens there is the client basically makes digitally an impression of what their voice may look like. And the therapist acts as the voice, making that digital representation talk, and then facilitates the conversation that way. That can be done with a screen. It can be done with a virtual reality headset. The less expensive way of doing that is for you and the client to make a mask, or have the client make a mask and put the mask in the chair and facilitate it in that way. Again, 2 small pilot studies comparing avatar therapy with treatment as usual. Large reductions in both trials. Case studies show clients' voices reduced by 80 to 90%. And by the 3-month follow-up, depression scores were still significantly reduced. So working directly with the voice is a powerful tool that we can use. Again, lots of decreases in symptomology with avatar. Avatar therapy is more realistic. And interestingly, the more realistic it is, the better it is for the client, the more improvements there are. 1 year random controlled trials with avatar therapy. Large effects on the PSI-RATS, pretty moderate on frequency, and a whole lot of improvement on persecutory beliefs, and overall symptomology had declined as well. So using a mask is fine if you want to do that, since we don't have those. If anybody does have a place where they can get a hold of a virtual reality that you can program, that might be kind of interesting to do. I know that they're out on the market somewhere. If we combine CBT and avatar therapy together, it's, look at the effect size. It's remarkable. It's remarkable. So that is a first view skim of Empty Chair with Voices. That's not all there is to it. I know it seems kind of odd to do a role play in that way, but it is very powerful. And one of the things that you might want to do prior to using it with somebody with psychosis, to use it with somebody who doesn't have psychosis, a client that you have who has unfinished business, perhaps with somebody who's died or is having a conflict with, and needs to do that unfinished business in the office rather than with the person in real life. So that's the overview of it. I do have a second Empty Chair work, part 2, that I can do as well, if you'd like to hear that at some point in time. But I thought I would share this with you as a really powerful way to begin to look at working with voices in a different way than what we might usually do. And that's it.